Welcome to the September 2016 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 5 scientific articles published in the September issues of the journal, as well as a commentary by Dr. Joshua S. Everhart on the article entitled, Hospital Discharge Within 2 Days Following Total Hip or Knee Arthroplasty Does Not Increase Major Complication and Readmission Rates. Be sure to check out this month's Current Concepts Review article on bone lengthening in the pediatric upper extremity by Dr. Sebastian Farr and colleagues. The authors note that bone lengthening has been used successfully for several congenital and acquired conditions in the pediatric clavicle, humerus, radius, ulna, and phalanges. Common indications for bone lengthening include achondroplasia, radial longitudinal deficiency, multiple hereditary exostosis, brachiometacarpia, symbrachydactyly, and post-traumatic and post-infectious growth arrest. This review article focuses on the historical background, biological basics, technical issues, results, and possible complications associated with bone lengthening procedures in the pediatric upper extremity. In this issue, JBJS.org presents a new image quiz, a 14-year-old girl with wrist pain and swelling. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 5 that are being presented in this podcast. This abstract is from the article entitled, Hospital Discharge Within 2 Days Following Total Hip or Knee Arthroplasty Does Not Increase Major Complication and Readmission Rates by Dr. J. Carl Sutton III and Associates. Investigation performed at the Department of Orthopedic Surgery, Jewish General Hospital, Montreal, Quebec, Canada. The rising costs of total knee arthroplasty, TKA, and total hip arthroplasty, THA, have resulted in a substantial economic burden on the U.S. healthcare system. Recent efforts to contain these costs have targeted hospital length of stay. However, shorter hospital admissions have raised concerns over possible increases in complications and readmission rates. The purpose of this study was to assess whether early discharge from 0 to 2 days postoperatively was associated with increased 30-day major complications and readmissions, compared with standard discharge 3 to 4 days following THA or TKA. The National Surgical Quality Improvement Program database was queried to identify all patients who underwent an elective primary unilateral THA or TKA between 2011 and 2012. For each procedure, 2 groups were created consisting of patients discharged from 0 to 2 days and those discharged from 3 to 4 days. Patient demographics and perioperative variables were compared between both discharge groups. Multivariable logistic regression models were used to assess the independent effect of length of stay on 30-day major complication and readmission rates. A total of 31,044 patients who underwent TKA and 19,909 patients who underwent THA were included. Overall, patients who were discharged early were younger and had fewer medical comorbidities and a lower American Society of Anesthesiologists score. The multivariable logistic regression model revealed that early discharge was not associated with increased odds of major complications following TKA. Furthermore, early discharge following THA was found to be an independent predictor against major complications. Lastly, early discharge was not an independent risk factor for hospital readmission following THA or TKA. Conclusions. Early discharge was not an independent risk factor for 30-day major complications or readmissions following THA or TKA. Rather, increased major complications and readmissions were attributed to patient comorbidities and perioperative variables. Early discharge within the first 2 days postoperatively for risk-stratified patients appears feasible without compromising patient care. Next, you'll hear a commentary by Dr. Joshua S. Everhart on the article entitled Hospital Discharge Within 2 Days Following Total Hip or Knee Arthroplasty Does Not Increase Major Complication and Readmission Rates.
This is Dr. Joshua S. Everhart providing commentary for the September 2016 JBJS podcast. I will be providing commentary on the article entitled Hospital Discharge Within 2 Days Following Total Hip or Knee Arthroplasty Does Not Increase Major Complication and Readmission Rates. The title of my commentary is Discharge Within 2 Days After Primary Total Knee or Hip Arthroplasty is Safe for the Right Patient. Reduced length of stay following elective hip and knee arthroplasty is an obvious target for cost savings, but is it safe? The answer is a cautious yes for the right patient. The authors of this study do a commendable job of tackling the question via use of the National Surgical Quality Improvement Program, or NSQIP, database. Specifically, they divided primary arthroplasties performed among NSQIP participating hospitals in 2011 and 2012 on the basis of length of stay, with early discharge defined as discharge 0 to 2 days postoperatively and standard discharge 3 to 4 days postoperatively. The authors then carefully compared 30-day major complication and readmission rates. From 2011 to 2012, 31% of the primary hip arthroplasties and 21% of the primary knee arthroplasties at NSQIP hospitals fell into the early category, and after controlling for demographic and clinical differences between the groups, complications and readmissions were no worse in the early discharge group. In fact, early discharge after total hip arthroplasty was actually associated with a small but statistically significant reduction in complication rates. These are encouraging results and suggest that a standard stay of 3 to 4 days is often not necessary for the average patient scheduled for primary total knee or total hip arthroplasty. What the study does not support is indiscriminate use of an early discharge pathway for everyone. As the topic of length of stay and its relationship to complication and readmission rates continues to be revisited in the literature, it has become increasingly apparent that patient and perioperative factors rather than length of stay are the primary driving force behind most early complications and readmissions. As Sutton et al. Appropriately point out, well-known risk factors for early complications, such as tobacco use and increased body mass index, still apply, regardless of length of hospital stay. Similar findings were identified by Smistowski et al. Medically complex patients had higher readmission rates, and shorter length of stay did not increase readmission rates. A major caveat to the apparently neutral effect of early discharge on complication and readmission rates on appropriately risk-stratified patients is the case of the patient who develops a new hospital-acquired condition in the early postoperative period. There is particular danger for early readmission of the patient who develops a new hospital-acquired condition, as Raines et al. Pointed out in a recent study utilizing data from the Veterans Affairs Surgical Quality Improvement Program, and this accounted for 42% of all readmissions in their data set. I would argue that providers should immediately reassess the discharge plan, specifically the timing of both discharge and the first office follow-up, for any patient with a new hospital-acquired condition after total knee or hip arthroplasty and have a low threshold for delaying discharge. Sutton et al. Noted that even after controlling for length of stay and medical comorbidities, there was a higher 30-day readmission rate among patients who were discharged to an extended care facility, or ECF, rather than to home, and a higher complication rate among total knee arthroplasty patients discharged to an ECF. Smistowski et al. Saw a similar phenomenon with increased readmission rates after ECF placement. I find this troubling. This may be due to a low threshold among ECFs for sending patients to a hospital for evaluation because of legal concerns for misdiagnosis or delayed treatment of a complication. Perhaps some aspect of patient health or risk of complication that is not fully captured by the NSQIP or other databases leads to a preferential placement of some high-risk patients in an ECF. Regardless, as readmission rates, whether fair or not, become a surrogate measure of quality of care, I suspect that we will see more work in the next few years aimed at better understanding and reducing readmissions from ECFs. In conclusion, early discharge within 2 days after a primary knee or hip arthroplasty does not confer higher risk of an early complication or readmission in appropriately selected patients. Patients with a high complication risk due to preoperative factors, such as increased BMI, or intraoperative factors, such as prolonged operative time or increased blood loss, remain higher risk regardless of length of stay. Early discharge plans should not supplant good clinical judgment, and a low threshold should be used to delay discharge or modify follow-up plans for patients who develop a new hospital-acquired condition in the early postoperative period.
Next, you'll hear the second abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Repairing the Capsule to the Transferred Coracoid Preserves External Rotation in the Modified Latarjet Procedure by Dr. Yoshiaki Itogawa and Associates. Investigation performed at the Mayo Clinic, Rochester, Minnesota. It is not clear whether the anterior capsule should be repaired to the coracoid process or to the native glenoid during the modified Latarjet procedure. The authors investigated joint stability and range of motion of the shoulder after the modified Latarjet procedure with both of these methods of capsular repair. 18 fresh frozen cadaveric shoulders were used. After a Bankert lesion and 6 mm glenoid defect were created, the coracoid process was transferred to the glenoid and fixed with screws. The anterior capsule was repaired either to the coracoid process or to the native glenoid. The ranges of internal and external axial rotation were measured with the arm at 0 degrees and 60 degrees of glenohumeral abduction. The range of motion was measured with a constant torque of 200 Newton millimeter. Joint stability was measured using a custom stability testing device. The stability ratio in the anterior-posterior direction was measured with the arm at maximal external rotation and neutral rotation. The range of external rotation was greater at both 0 degrees and 60 degrees of abduction in the coracoid group compared with the glenoid group. The range of internal rotation was not significantly different between groups. The end-range stability ratio was not significantly different between groups, but the mid-range stability ratio was significantly greater in the glenoid group. Conclusions. Because the difference in the mid-range stability may not be clinically relevant, the authors recommend repairing the capsule to the coracoid, as that preserves the range of motion in external rotation. Next, you'll hear the third abstract of 5 that are being presented in this podcast. This abstract is from the article entitled The Readability of AAOS Patient Education Materials, Evaluating the Process Since 2008 by Dr. Heather Roberts and Associates. Investigation performed at the Department of Orthopedic Surgery, Brigham and Women's Hospital, Boston, Massachusetts. The Internet has become a major resource for patients. However, patient education materials are frequently written at relatively high levels of reading ability. The purpose of this study was to evaluate the readability of patient education materials on the American Academy of Orthopedic Surgeons AAOS website. Readability scores were calculated for all patient education articles on the AAOS website using 5 algorithms: Flesch Reading Ease, Flesch Kincaid Grade Level, SMOG, Simple Measure of Gobbledygook Grade, Coleman-Liao Index, and Gunning-Fogg Index. The mean readability scores were compared across the anatomic categories to which they pertained. Using a liberal measure of readability, the Flesch Kincaid Grade Level, 3.9% of articles were written at or below the recommended 6th grade reading level, and 84% of the articles were written above the 8th grade reading level. Articles in the present study had a lower mean Flesch Kincaid grade level than those available in 2008. Articles categorized as hand and wrist or foot and ankle had significantly lower mean Flesch Kincaid grade level scores than the mean for all categories. Conclusions. Regardless of the algorithm used, the mean readability levels of AAOS articles are higher than generally recommended. Although the mean Flesch Kincaid grade level was lower in the present study than it was in 2008, a need remains to improve the readability of AAOS patient education articles. Next, you'll hear the fourth abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Development and Validation of a Preoperative Surgical Site Infection Risk Score for Primary or Revision Knee and Hip Arthroplasty by Dr. Joshua S. Everhart and Associates. Investigation performed at the Wexner Medical Center, The Ohio State University, Columbus, Ohio. Surgical site infection, SSI, is a major complication following total joint arthroplasty. Host susceptibility to infection has emerged as an important predictor of SSI. The purpose of this study was to develop and validate a preoperative SSI risk assessment tool for primary or revision knee and hip arthroplasty. Data for 6,789 patients who underwent total joint arthroplasty were obtained from a single hospital system. SSI was defined as a superficial infection within 30 days or deep infection within 1 year. Logistic regression modeling was used to create a risk scoring system for a Derivision sample with validation performed on a holdout sample. On the basis of logistic regression modeling, the authors created a scoring system to assess SSI risk that is the point sum of the following: primary hip arthroplasty, primary knee, revision hip, revision knee, non-insulin-dependent diabetes, insulin-dependent diabetes, chronic obstructive pulmonary disease, inflammatory arthropathy, tobacco use, lower extremity osteomyelitis, or pyrogenic arthritis, pelvis, thigh, or leg traumatic fracture, lower extremity pathologic fracture, morbid obesity, primary bone cancer, reaction to prosthesis in the last 3 years, and history of staphylococcal septicemia. The risk score had good discriminatory capability and calibration and was validated using the independent sample. A small subset of patients had a greater than 10% estimated infection risk. Conclusions. The patient comorbidities composing the risk score heavily influenced SSI risk for primary or revision knee and hip arthroplasty. The authors believe that infection risk can be objectively determined in a preoperative setting with the proposed SSI risk score. Next, you'll hear the fifth abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Patient Compliance with Postoperative Lower Extremity Non-Weight-Bearing Restrictions by Dr. Christopher P. Chiodo and Associates. Investigation performed at the Department of Orthopedic Surgery, Brigham and Women's Hospital, Boston, Massachusetts. A period of non-weight-bearing is prescribed following many orthopedic injuries and procedures. It is believed that a period of non-weight-bearing is important for proper healing and recovery. The degree to which patients are compliant with non-weight-bearing instructions is unknown. The purpose of this study was to measure patient compliance with a period of prescribed non-weight-bearing. In this single-blinded study, pressure-sensitive film was embedded into short leg casts of 51 consecutive adult orthopedic patients with unilateral lower extremity abnormality who had been instructed to be strictly non-weight-bearing. Sensors were retrieved at the time of cast removal and then were analyzed for force distribution and magnitude. Non-compliance was defined as maximum detectable pressure exerted on 50% or more of the film. Patient characteristics and the time of year that the casts were worn were also examined to determine if they correlated with weight-bearing. 14 of 51 patients were non-compliant with the non-weight-bearing restriction. 6 of the 14 non-compliant patients, compared with 11 of the 37 compliant patients, experienced an adverse event. Sex, age, language spoken, body mass index, time in the cast, and the treating surgeon did not have a significant influence on weight-bearing performance. Significantly greater weight-bearing was found in warmer months than in colder months in the United States. Conclusions. The non-compliance rate with the postoperative non-weight-bearing restriction was 27.5% in this patient group, despite explicit instructions and education about possible complications associated with weight-bearing. The only factor found to have a significant effect on weight-bearing compliance was the time of year that the cast was worn. No significant difference was found between the complication rate of the compliant patients and that of the non-compliant patients. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.